welcome you all to the today's webinar that's on GAIT in stroke, an evidence-based approach in assessment and management. Recently, we had a workshop in our department. So we have discussed a little bit about this GAIT in stroke, and this is a little bit a larger version of that presentation. I hope this will help you in deciding what type of approach you will go for deciding the protocol of management in case of stroke with a abnormal gait. So if you look to the incidence of walking after stroke, walking is the primary target for rehabilitation as far as the patient is concerned and as far as the caregiver is concerned. The prime motto of rehabilitation in stroke is first priority is ambulation, second priority is ADL maximization. So if you look to the literature, as per this study, around 23 to 37% of stroke patients, they walk within the first week, 50 to 80% walk at third weeks, almost 85% walk at the by the 6 month of the history of stroke. Of course, these statistics may vary depending upon location of the stroke. Almost most of the cortical stroke, they are able to walk. So if you categorize the walking of stroke patients during the recovering period, they can be classified into physiological walkers, those walks for exercise only, either at home or in a parallel bars during physical therapy. Household workers again divided limited household workers, those who can work inside the home but they cannot do advanced activity. They can go for certain turn, negotiate in different doors or stairs. So those are limited household workers. Unlimited house workers, those are free. They are free. They can do all their ADL activities inside the home. And third group of patients are the community workers. They are again divided into three types. Most limited community workers, they are free to work inside the home, but when they come out of the home to the community, they have limitations, especially in slopes and ramps and stairs. They have limitations. Least limited community workers and community workers means they are work with very limitation. They can walk around in the community. So this is depending upon the prognosis of the gait, they can be classified in these three categories. So basically we are discussing on the hemiplegic gait. The most common type of gait we come across in stroke is the hemiplegic gait, otherwise called circumduction gait. If you look to this picture, this is the normal limb progression, and this red is the paralytic side of progression. We almost all know what is a hemiplegic gait. There is a relative lengthening of the limb because of insufficient hip flexion, insufficient knee flexion, insufficient ankle dorsiflexion. That leads to apparent lengthening of the limb, and for the ground clearance, the patient has to lean to the opposite side toward the healthy side and circumduct the limb for clearing the ground, as it happens in all types of apparent lengthening conditions. So this is a typical gait in case of stroke. However, the gait may vary some extent. Trendelenburg can be attached with that when abductors are weak, and sometimes in chronic stroke when there is knee flexion contracture, they can walk with a knee flex gait. However, the commonest type of gait we come across in stroke is the this hemiplegic gait or circumduction gait. So what is that gait? If you say normal gait, it is the smooth forward propulsion of one center of gravity along the desired line of progression in space by well coordinated cyclical repetition of motions in all four limbs and trunk. So if any deviation to the propulsion of the center of gravity, any deviation to progression of the limb in a definite desired line, is there any incoordination of these steps? All this can happen in case of a stroke, And why this happen? It's because of CNS center. We all know it's a cortical involvement, the cerebral involvement, or subcortical involvement. It's a central nervous system involvement. So why this central nervous involvement leads to a abnormality in the gait? What are the requirements of the central nervous system for the locomotion? That is, locomotion control is distributed across the discrete regions of the CNS. It's not a particular region for which the gait is depends on. This is it's distributed across the central nervous system. Walking is the primary walking is primarily brainstem and spinal cord function, and that's there in the locomotor central pattern generators, which is present in the spinal cord. So that's a part of the spinal cord, and that's why the when you compare the logo gait in case of a spinal cord injury in a stroke, the ambulation of the gait improvement is much better in stroke when there is a spinal cord is intact, only cortical or the cerebral involvement is there. So this is the locomotor central pattern generator which is present in the spinal cord. Then integrating command centers have been identified in the medial medullary reticular formation to coordinate the activities for the gait. So that's why the patients with cortical stroke may be able to regain the ability to walk in the very early stage. There, the subcortical areas, other coordinating areas are intact. So get almost improve better in case of pure cortical strokes. So what are the important requirements of locomotion from central nervous system? It is coordinated movement, equilibrium of the patient, the person, and adaptation of the gait depending upon the different environmental conditions. So all these three things are possible by active involvement of the central nervous system. As I said, the one important part is the central pattern generators. That is a group of neurons or circuits that can generate a coordinated rhythmic movement autonomously for locomotion, and it is located in the spinal cord. So that's very important why the improvement of gait is much earlier in case of stroke. And second part, equilibrium, as I said, is also equally important for locomotion. So here the vestibulocerebellar system is also responsible for providing equilibrium. Besides that, and for adaptation purpose, your vision is should be intact. Vision should be normal for adapting to different environmental conditions. That also improve gait. Other important structures are cerebellum, basal ganglia, cerebral cortex. All these things involved in the adapting different types of locomotor patterns and adjusting to the environmental conditions, maintaining a balance. All these things are important in relating the central nervous structures to the gait pattern. So in a normal person, the gait, as we all know, divided into two parts. Stance phase, the major phase of the gait, constitutes around 62%, and swing phase constitutes around 38%. But the relation between the gait speed and phase duration, if the in a slower speed, when the person walk with a slower speed, the stance phase is more than the swing phase. When the person walk with a faster speed, that is running, the swing phase is longer than stance phase. So that's how the speed and this stance swing phase varies along with the speed of the locomotion. So as far as the gait or the in case of stroke is concerned, what do we look for? Always look for what are the deviations happening in a normal gait during observation of the gait. So what are the prominent findings one should look for observation of the gait analysis and gait deviations? That is weight acceptance, single limb support, and swing limb advancement. We all know there are a traditional method of division of the gait cycle. There is a RL, Rancho Los Amigos method of classification of gait cycle. So weight acceptance or heel strike in case of traditional term, or RLA, it is initial contact. That is important for deciding the type of gait in case of stroke or any other type of abnormal gait when we examine. So what is the nature of weight acceptance? Whether it is a forefoot is initial contact, heel is initial contact, or midfoot is initial contact. What is the weight acceptance? Whether it is any type of gait disorders. Then what happens to the body in single limb support period in stance phase. And third one is how limb is progressing in case of swing phase. So these, of course, these are the different stages like initial contact, loading response, then mid stance, late stance, toe up, pre-swing. All these are stages of the gait. However, we more concentrate on weight acceptance, what is the status of the body and limb in single limb support in stance phase, and swing limb advancements. These three things are important when we observe a gait, when we observe a gait and gait abnormality in a particular disease condition. So, an important task to accomplish in case of gait in stroke is maintaining the support of the limb segment during the stance, clearing the foot during the swing, and supplying enough energy to move the energy conserving measures. So the basic principles of gait correction in stroke is how the patient is bearing his weight on the stance by the affected or paretic side, and how he is clearing the foot in the pre-swing stage, and how limb is progressing in swing stage. So these three things we always look for, we always concentrate to correct abnormality of these three stages of the gait in case of stroke. So gait deviations usually occurs with walking speed, distance, stance phase versus swing phase, double limb support versus single limb support. These we are talking of regarding spatiotemporal parameters. This spatiotemporal parameter starts with walking speed and distance. What is happening to these spatiotemporal deviations in case of stroke gait? These are most important parameter as far as aesthetic gait is concerned. Whether the gait, the pattern looks normal, aesthetically normal in comparison to the healthy side, normal limb or not. So that's the most important parameter. Speed in a stroke is significantly lower than a much able-bodied person, a normal person. If you look at the average speed of a stroke patient, it is around 0.23 to 0.73 meter per second, which is almost less than half of a normal individual. For a normal individual, the gait speed is around 1.4 to 1.6 meter per second. So in a stroke individual, the speed is much less than 50% of a normal individual. You can say that the fastest speed of a stroke patient is lower than the slow speed of a healthy people. So overall, there will be walking distance will be limited in case of stroke gait. So what happened to the stance phase and swing phase? What is the relation between these two phases in case of stroke gait? There is always asymmetry in step length, and swing time is a strong features of hemiplegic gait. What happened in that condition? Stance phase of both affected and unaffected side is more than in the able body. Just think of for a circumduction in the paretic side when it is a swing phase, which is most prominent features in the gait. It is a circumduction. What will happen? That circumduction will take a more time. That means the swing phase will be broader. So unless the swing phase of the paretic side is not completed, the healthy side limb is already on the ground. So that means both stance phase of the both affected and unaffected side both will be increased than a normal person. Swing phase is increase in paretic side, stance phase is increase in healthy side. As I said, that both stages correlate with each other. Okay, then prolonged paretic and non-paretic double stance phase, and there is always a step length asymmetry. It's obvious the cadence will be decreased and the gait speed also decreases in case of stroke. All these parameters needs to be identified and need to be corrected during correction of the gait. And next part is appearance and asymmetry. As I said, the gait asymmetry is also important. Anybody who can tell looking towards the stroke patient, no, his gait is not normal. This simple observation of layman also. So everybody is conscious about the aesthetic aspect of the gait. Here, there is a temporal asymmetry. There is single limb support of unaffected side is more. And in case of distance asymmetry, there is a reduced step length in an unaffected limb, whereas average step length of both the limbs are also reduced. So since the pyretic side, there is the spasticity of the hip flexors, the weakness of the hip extensors, so limb progression is poor. That's why the step length on the affected side also, or pyretic side also, reduced. Asymmetry in different joints and body parts during the gait, that also very much prominent in case of circumductor gait. As I said, limb has to rotate it to clear the ground for the progression of the limb. The trunk has to bend towards the normal side to lift up the leg for clearing the ground. So all these things, these abnormalities are very obvious. Achievement of the gait symmetry used to be important objective in rehabilitation and considered as a parameter for successful rehabilitation. As this is very obvious for even a normal individual also can notice that yes, the patient is having some paralysis and his gait is abnormal. So everybody, the caregiver, the patient, they are conscious about the aesthetic looking of the gait. So, whether this aesthetic looking is really related to his function or not, that is a question. That is symmetry versus gait speed. Gait speed is a function. So, how it is related? There is a weak evidence that symmetry played any role in improving the speed. So, our argument of improving these temporospatial parameters, kinematic symmetry, is only aesthetic one only. So aesthetic gait will not improve the speed of the patient, but yes, the gait improves, that the ugly looking gait can be avoided. If you say functionally it is not improving. Now, after the temporospatial parameters description of the gait in case of stroke, the next part is the what are the kinematic deviations in the stroke gait. These kinematic deviations are due to, this is because of a reduced strength of the muscles, inappropriate timed muscle activity, that is timing problem. It is, as we all know, this is central nervous system disorder of cortical origin. So what will happen that there is always a synergy problem here. There is always a dyssynergy between agonist and antagonist group of muscles. When agonist is contracting, antagonist must be relaxed for effective action of the agonist. But in this case, agonist and antagonist sometimes both are contracting. So there is always a timing problem, inappropriate muscle activity, which leads to kinematic deficiency of the gait. Production of inappropriate excessive active tension in certain group of muscles. For example, in case of normal common type of gait, hyperextension gait or circumduction gait, there is inappropriate action of the quadricep group of muscles, which say keep the knee in extended position, and there is failure of hamstrings contraction. So all these things related to a hyper circumduction gait. Changes in mechanical properties also happen in long-standing chronic cases. There is a study which says that how the muscle behave in a different way in case of stroke. This study shows that there are four types of muscles groups in case of stroke, and they behave completely in a different way. In type 1 group of muscles, there will be premature activation of the calf muscles whenever it is stressed, like in case of the circumduction gait. During the toe up stage, the muscle gets stretched during body propulsion. The body will try to push up with that equinus or spastic equinus gait. So that stretching again causes further contraction of the gastrosoleus. The foot and ankle remain in plantigrade position. That also increases apparent length of the limb, for which the person has to circumduct. Then second group of muscle, lack of muscle activation, and in two or more major group of muscles. Like in that condition, in swing phase, the hamstring is supposed to contract in the early stage, pre-swing and mid-swing stage for the ground clearance and limb progression of the pyretic limb. But that muscle is not activated in the right time. So that comes under type 2. Type 3 EMG study shows that there are a combination of type 1 and type 2 muscles present in the same patient, that creating GAIT abnormality. There will be co-activation of the several muscle groups. One group is activated, other groups are inactivated. So normal sequencing is disrupted. That is that flexion extension synergy activation. So that also creates a abnormality in GAIT. And type 4 variety showing combined components of other three. 1, 2, 3, all groups can be seen in a single person. So all these different behavior of the muscles leads to GAIT abnormality. In their study, they conclude here each patient has a unique motor control problem during the locomotion. So each patient differ from each other. No two patients are same, and these different muscle behavior of muscles in different way can coexist. Type 1, type 2, or type 1 and 2, they coexist in a same person. Now coming to see what is happening, what are the kinematic deviations happen to different levels in the stance phase of the GAIT in the case of a stroke GAIT. So in stance phase, if you look to the hip abnormalities, deviations, what will happen during the initial contact? There will be reduced hip flexors in initial contact. If you see closely observe a circumduction GAIT, as I said, the gait speed is reduced. The step length is reduced. Why? Because the limb is not progressing properly. The hip flexors are poor here. So it is not progressing to an adequate length to maintain the normal step length. So how it happened? It's because of inability to activate hip flexors sufficiently, like type 2 group of muscles, or inadequate relaxation of the hip extensors. Either can causes a reduced hip flexion in initial contact. Next part is mid stance. During mid stance, because of inability of activation of hip abductors sufficiently, patient may develop a Trendelenburg. And that Trendelenburg, by switching the trunk to the paralytic side, that also helps in clearing the affect paralytic limb on the paralytic side. And third problem is in the terminal stance, where there is a reduced hip extension. So all the way from terminal stance, initial contact, mid stance, and terminal stance, when the limb is ready for propulsion to the pre-swing stage, that stage also there will be reduced hip extension. So by that, the terminal stance also affected. There will be adaptive shortening of the hip flexors, which inhibits the hip to be extended. So this happens in case of chronic stroke. So hip is affected in all the way from initial contact, from mid stance and terminal stance. All these things leads to a reduced step length, and all these things leads to a circumduction, reduced step length. So this is the kinematic abnormality seen in case of hip. Then coming to knee and foot and ankle, what is happening? We all know that knee get hyperextended in the stance space. Why it is happening? Because of production of excessive active tension in the and adaptive shortening of the plantar flexors. As we all know, when there is a plantar flexion, there will be knee hyperextension, as the center of gravity, the ground reaction force passes in front of the knee when the foot and ankle is equinus. So that is one cause of knee hyperextension. And second cause of knee hyperextension is inappropriate eccentric control of the knee extensor. So there will be excessive contraction of the knee extensors, and there is a plantar flexion spastic plantar flexion deformity. So these two things leads to hyperextension of the knee in the stance phase. Then increase knee flexion in stance phase in late cases. In case of late cases, chronic cases, they are develop adaptive shortening of the knee flexors. So that leads to a knee flexion in stance phase, mid stance phase. Third is increase of, and coming, this is about knee part. Then coming to ankle part, there is increased ankle plantar flexion in the initial contact, which leads to the initial contact will be either it is a forefoot or it is a flat foot, never being a heel strike. So that's because inability to produce sufficient active tension in the dorsiflexors at the initial contact, and there is excessive tension in the plantar flexors. So dorsiflexor weakness, plantar flexor overactivity leads to initial contact being the forefoot or flat foot. The next, the foot and ankle problems is reduced plantar flexion in toe-up stage. That's again important. Why step length is increased? Because the foot is already in plantar flex position during toe-up, during the push-up. You know, a muscle will work better when it is stretched to a maximum extent. So in a normal person, during the from mid stance to toe-up stage, it goes from dorsiflexion to plantar flexion. So when the muscle in the mid stance phase towards late stance phase, the foot is dorsiflex, the tibia roll over the ankle, the plantar plexus are stretched. That initiates the triggering action or the contraction of the muscle. We all know a stretched muscle contracts better than a lax muscle. So in this case, the foot is already in stretch position, the plantar plexus are already in stretch position, so there will be insufficient push up. That leads to insufficient push up and reduce of the step length. So all these are the deviations, kinematic deviations at the knee level, at the foot and ankle level. Now coming to swing phase. What are the swing phase deviations? It is clearly well marked in hemiplegic gait in the circumduction gait. That is mostly obvious in the swing phase. That's because of inability to produce sufficient active co-contraction of the hip flexors, and there is insufficient relaxation of the knee flexors, and there is insufficient relaxation of the dorsiflexors. All this leads to a apparent lengthening of the limb, and patient try to clear the ground by doing circumduction. So what other changes are there? Reduced peak knee flexion in early swing phase. In a normal person, early swing phase, knee is normally flexed to 40 to 60 degree of flexion in the early swing phase, which is not seen in case of stroke gait, and knee remain in extended position, and there occurs apparent lengthening and circumduction for the ground clearance. When coming to the towards the end of the swing phase, that is towards the heel strike, that is late swing and heel strike. At this junction, the knee at the mid stance mid swing phase was in flexion. Then towards end of the swing, the knee has to be extended, prepare the limb for the initial contact, right? So in that situation, there is reduced ankle dorsiflexion, increased plantar flexion, so the toe will drag. In that situation, normally it should be the knee should be extended from 30 degree flexion to 0 degree, so that the limb will be ready for initial contact, and at the same time also there will be reduced ankle dorsiflexion, increased plantar flexion, for which there will be toe drag, and initial contact will be the forefoot. So these are the deviations occurs in case of stroke. You can very well examine these things under the observational gait analysis. Take a video of the gait of the child or person. See what are the different abnormalities going on in different stages of the gait cycle, in stance phase, in swing phase, and what is happening to hip, what is happening to the knee, what is happening to foot and ankle, and what is happening to trunk. So all these things can be individually seen and analyzed, and accordingly one can plan for next management. So any form of gait energy expenditure is important part. As far as the gait is concerned, it should be there should be least energy expenditure during the gait, which is normally oxygen consumption per kg per minute is normally calculated. It can influence how fast, how far a patient chooses to walk, and at a comfortable speed. Patient with a stroke tend to have a lower oxygen consumption. Why? Because they have a so the distance cover in a particular time is less. The mean consumption of this energy consumption for normal person is 13 ml per kg per minute, whereas in case of stroke patient, it is 10 ml per kg per minute. So although energy consumption is less, but the oxygen consumption per unit per distance travel in patient is more. Why? It is because during a particular time period, the distance cover is less. That's why the overall oxygen consumption is patient is more in these cases. So energy expenditure during hemiplegic gait, as per this study, that the transformation of potential energy to kinetic energy, which occurs with each step, that minimizes the external work performance in normal level working. So more the center of gravity movement is there, more energy consumption is there. So body for a normal person, always we try to limit the excursion of center of gravity during our normal locomotion. By that, the energy consumption can be limited. But because of the abnormal kinematic at different levels of the joint, abnormal trunk movement, the center of gravity movement is more in case of stroke, and there will be overall energy consumption will be more. So what are the determinants of gait performance in case of stroke? We all know muscle strength is most important, mostly consisting, and this is consistently and highly correlated to the gait appearance, independence and endurance, speed and cadence. Balance is second important. Spasticity need to be addressed. Sensation and especially cortical sensation and perception of verticality. How the person is behaving while in the stand space. It appears to correlate at least in the right brain region. So these are the certain parameters to be addressed by. Also we have to recommend the therapists to address these things also. So now coming to management part, what are the evidences, different forms of management in stroke correction? So as far as the locomotion is concerned, we have a traditional method of management for the stroke patient. We have a instrumental method of management of using different type of instruments for improvement of the gait. So gait retraining therapy in stroke is by conventional method or by special methods like repetitive task training, treadmill training without body support, treadmill training with body support, virtual reality stroke gait training, EMG biofeedback treatment in lower extremity. These are equipments used for improving the gait pattern. However, still the traditional method of gait improvement is still there. If I'll discuss something about the traditional method of gait correction before jumping to the instrumental methods of gait correction. In traditional method, basically, as I said that the patient is in a flexor synergy for the upper limb, extensor synergy for the lower limb. So in that situation, we have to break the synergy, we have to break the movements, we have to find the missed component of the movement. If you look to the gait in stroke, a circumduction gait, what are the components are missing in that gait? The most important component missing is the knee flexion. So that is the major cause of gait abnormality. So missing component here is the knee flexion. What second component missing here is the ankle dorsiflexion. So these two components are missing in case of in case of gait in stroke. And in a traditional method of gait management, we focus on these missing components by giving repeated training to the brain, re-educate the brain to enhances the neural plasticity to record this missing component of the gait. So how do we do that? We ask the patient to go for repeated short function of the knee flexion, ask the patient to go for half squatting, ask the person supported stair climbing or over step riding. So each time person has to hammer to the person that to flex the knee. So repeated sit stand, ask the patient to sit on the chair, then stand, sit and stand, sit and stand. Then step up and step down, step up and step down, even with support also. That helps in reminding the brain about the missing component of the gait of the knee flexion. And Second part, like suppose the person is not ambulatory, he cannot go for step climbing, or he cannot go for hop squat, he cannot go for sit to stand from a chair. So that situation you can enhance by asking the patient lie down the bed, and the paratic side has to be hang on the side with extension of the hip and at the side, and the patient is asked to elevate the limb to the crouch with hip flexion, knee flexion, and keeping the foot in plantar flexion on the keep the foot the dorsiflexion on the couch. So each time the limb has to be parietal limb has to dip down on the side of the couch, again taking up to the couch with hip flexion, knee flexion, and ankle to plantar dorsiflexion. So these missing tasks are repeatedly trained to the patient by repetitive task training. Thereby also one can improve GAIT. That's a traditional method of breaking synergy and also repeated task training for training the missing component of the GAIT. So this is about the traditional therapeutic part for improving GAIT. Coming to the GAIT training with instrumental methods. So let us start with what is repetitive task training, as it is required for the instrumental GAIT training, or as well as also by conventional method of GAIT training. So here it takes a typical task that we do in the daily life, such as, like, suppose somebody wants to take a glass of water. The person may not have complete the task, but that glass, for the taking glass of water, we have to flex the hand, flex the elbow, then extend the elbow, open the fingers, then catch hold the glass. So if you take the whole activity as one component and break into different parts, the shoulder has to flex, elbow has to be extended, the hand has to be open. So each component has to be break and see what is happening, which component is missing here. So the whole total task is break in different components, and the missing component has to be trained repeatedly. The individual is then taught small components of the movement, such as straightening out their elbow over and over again, or repeated standing practice, repeated walking indoor and outdoor. We ask our patient to walk on the corridor with use of parallel bars which are there on the attached the wall. So they also go for repeated task training. So we always encourage our patients to go for walking every day morning. If there is no, it's not a therapy period, you can do therapy yourself by walking with the help of this parallel bar. So this repetitive task training is the cornerstone of all types of therapeutic maneuvers in as far as the stroke gait correction is concerned. So for this repetitive task training, we have taken, for evidence purpose, we have taken 10 RCTs with a common inclusion criteria, having all RCTs 1 year up to first stroke. There is no history of second stroke. The patient able to understand the verbal commands what the therapist is asking, able to walk with or without walking aids. These are the prerequisites inclusion criteria of these all RCTs. What the evidence shows, all RCTs have, you can see all RCTs have a good Pedro's score of more than 6, which says that these are good RCTs. So if you look to the outcomes in these the 10 RCTs, that the different components which are improved in case of repeated task training by different means are strength and balance, walking speed and capacity, walking competency, walking distance, additional backward walking and training, strength. All these activities are improved by repeated task training. So this or 10 RCTs conclude with this. They conclude that there is a strong level 1 evidence that repetitive task training techniques can be used to improve gait in post-stroke. However, the current study on in a Cochrane review says that this systematic review includes 32 randomized controlled trials. Out of that, one is quasi-randomized trial involving 1,853 patients, stroke patients. They found that there were no difference in functional ability after treatment according to the number of hours of training. All this is about the repetitive task training, the time from stroke to training, or the type of training delivered. These three components has no relation with overall improvement of the gait, but not all the things. So repetitive task training was effective in the first 6 months, but no difference between the groups was seen after 6 months. So this first 6 months is the most neuroplasticity period where a brain can be re-educated the missing task of the locomotion, and that's how the improvement, as per this Cochrane systematic review, says that improvement is more perceived in the first 6 months of the post-stroke period. So we have to target that first 6 months for improvement of the gait. Then treadmill training, again it's a traditional method. Treadmill training, this training offers opportunity for repetitive practice. This is another method of repetitive training practice for gait purpose, and this stimulates the brainstem and spinal cord locomotor pattern generator with reduced cortical, where there is a reduced cortical control. So treadmill is a traditional method. Before this body weight support treadmill system or computer or the robot associated treadmill system was available, the prior old method after the traditional method of gait correction is the treadmill training. It is simply a repetitive task training where by doing that, it stimulates the brainstem and spinal cord locomotor pattern generator, which is there in the spinal cord for improvement of the gait. It consists of ambulation of a motor-driven treadmill, which was adjusted to subjects' comfortable walking speed depending upon what is the condition, what is the spasticity of the person, what is the ambulatory potential of the person. Accordingly, the speed is decided, and this repeated training is achieved by ambulation of a motor-driven treadmill. During the treadmill training, the subject held either a front grab bar or a horizontal bar at the side, and the therapist has to provide assistance with the hip flexion and foot placement as and when needed. So you need to have therapist help for this treadmill training, which can be avoided later on by instrumental way of adding body weight support system or exoskeleton system for reducing the assistance or reducing number of persons assisting the gait training. So here also there are 6 RCTs. Of course, all are having good Pedro score, and the common inclusion criteria are mild to moderate hemiparesis detected by the physician. The observable gait deviations resulting from stroke is there. No other causes of weakness is associated. Able to stay 4 to 6 months as inpatient in the ward. Able to walk at least with 10 meter with or without walking aids. These are the inclusion criteria for these RCTs for evaluating the role of treadmill training. So what the literature says about that all this outdoor walking, non-aerobic exercise associated, this low intensity home exercise, these have positive association. Treadmill training, these are all have positive association with improvement of gait. However, the conclusion says that there is a strong level 1 evidence that treadmill training can improve the gait velocity in ambulatory patients in chronic stage of the gait. However, the gait symmetry has not well been established. Yes, the gait velocity is improved in case of treadmill training. What other studies says about that? This is a study which is published in Global Epidemiology, that is effectiveness of treadmill assisted gait training in stroke survivors. That's a systematic review meta-analysis where 8 trials were included in the study in this meta-analysis with 695 participants included in the inclusion criteria. They conclude that the treadmill training following stroke offers improvements in walking distance. However, it has no significant advantage in improving walking speed and balance over ground walking training. However, the treadmill training improved walking distance during the immediate post-intervention period is significant. So, immediately when you start doing treadmill training, you will get an improvement and patient will happy with that also. But in long run, there is no significant advantage in walking speed and balance when you compare with the gait training over the ground. The thought, the most commonly used nowadays for GAIT training is the partial body weight support treadmill training. Here, there is intensive task-specific training is promoted as one approach for facilitating neural plastic brain changes and associated motor behavior that gains following neurologic injury. Partial body support treadmill training is one task-specific approach frequently used to improve walking during the acute period of stroke recovery that can be used in case of non-ambulatory patient. The whatever we discussed earlier, that repetitive task training, treadmill training, the patient must be ambulatory with or without ambulatory aids. But here, this can be used in case of non-ambulatory patient. This is again one form of repetitive task training. But the advantage here is that even paralytic patients which are not ambulatory, this method can be used for improving the gait in a stroke. So what happened in case of partial body weight support treadmill training? That stimulates the brainstem and spinal cord motor parting generators with reduced cortical control. That limited weight bearing is there as is suspended, patient suspended from roof. Patient confidence is greater because of reduced risk of falling. Body weight support can be gradually withdrawn as the patient start bearing weight. Gradually the support can be withdrawn, and the best part is that the requirement assistance is less required in case of body weight support. Once the patient is made to stand over the treadmill by the therapist, afterwards the patient can go for GAIT training with minimal assistance. So what the literature says about this, the body weight support treadmill training, speed influence, paralytic and non-paralytic leg muscles activation, stride characteristics, and rating of perceived exertion during the acute stroke rehabilitation. The stride length, cadence, and paralytic single limb support increased with faster walking speed, while non-paralytic single limb support remain nearly constant. They conclude that during the acute phase of the stroke recovery, this partial body weight support treadmill training at the fastest speed promoted practice of a more optimal gait pattern with greater intensity of effort as evidenced by longer stride length, increase between limb symmetry, greater muscle activation compared to the training in the slowest speed. So this here the speed is under our control. Unlikely in case of traditional treadmill, here it can, since the patient is suspended his body weight by suspension mechanism. Here that speed can be increased or decreased as per our requirement, and this evidence shows that in this another of 8 RCTs is there, which says that there are only certain correlation between routine physio, and there is very limited evidence for improvement with a marked improvement in all parameters of the GAIT. So we have also other evidence supporting system. However, these 8 RCTs says that there is a conflicting level 4 evidence that the combination of partial body weight support and treadmill training results in improved gait performance compared with other physiotherapy interventions. So this is inconclusive as far as this concerned. This is concerned. See another study, a Cochrane review, which says that treadmill training and body weight support for walking after stroke. They compare. Here they include 56 trials with 3,105 participants. In this review, they used treadmill training in walking rehabilitation of people after stroke, increase the walking velocity and walking endurance significantly here. The use of treadmill training with body weight support in walking rehabilitation for people after stroke did not increase the walking velocity and walking endurance at the end of the scheduled follow-up period. So they conclude people after stroke who receive treadmill training with or without body weight support are not more likely to improve their ability to walk independently compared with people after stroke not receiving treadmill training, but walking speed and walking endurance may be improved slightly in short-term period by this body weight support treadmill system. So far, all the evidence says that still traditional method of walking has higher improvement in comparison to all fancy type of GAIT training modalities. Virtual reality also a part of in GAIT training that allows individuals to experience and interact with three-dimensional environment. As we all know, virtual reality, the environment is created, a three-dimensional environment is created. There is head-mounted displays or with the conventional computer monitors or projector screens, depending upon your type of VR you are using. So in case of advanced form of a human computer interface, it's an advanced form of human computer interface. It enables users to explore, interact, and immerse themselves in the environments that appears and feel similar to the real world objects and events with real time and augmented feedback about their performance through multiple sensory channels. So this we all are aware about this, that a environment, artificial environment is created to facilitate different types of movements by the parietic limb with auditory and visual signals. So what is the effectiveness of this virtual reality in rehabilitation after stroke? This systematic review says that the gait, mobility, and balance. Overall, 36 reviews assessed gait and balance, 18 of which reported superiority of virtual reality with or without conventional therapy over conventional therapy alone, whereas 17 found no difference between the groups. So still the result is inconclusive. As far as the walking distance speed is concerned, 6 meta-analysis assessed gait distance and speed. The meta-analysis of 6-minute walk test is found in virtual reality superior to conventional therapy. As far as work balance scale assessment, the superiority of virtual reality over conventional therapy in this assessment system. So still this also gives a mixed type of results over conventional therapy. Some component of the gait has improved, showing remarkable improvement with VR, and some are not, and some are with better with conventional therapy. So here the old letter RCTs are taken with common 4 RCTs are taken here for common inclusion criteria with chronic post-stroke hemiparesis. All are out of shock stage, and they able to face the real life scenario, and they must have a good cognition. So these are the different 4 RCTs here. They use VR with a different doses, but the outcome measures were functional aberration categories, modified motor assessment scale, walking speed, community walking time, and time up and go, 10-minute walk test, 10-meter walk test, 6-minute walk test. These are all gait assessment methods, or methods are used for assessment of virtual reality by these old literatures, this RCTs, and they conclude that there is a strong level 1 evidence, all are RCT, that shows that virtual reality training can be used to enhance gait recovery following stroke. The last one is the EMG feedback treatment in lower extremity post-stroke. That technique is using visual or sound signals to monitor muscle activity, which muscle is acting in which phase. That can be assessed whether when the antagonist is working, that time the agonist is relaxing or not. So that can be assessed, well assessed by EMG biofeedback system. The electrodes are placed on the skin surface above the muscle group being targeted. The electrical activity displayed to the patient in either visual or in auditory format, and patient is encouraged to use the weak part, and hence it helps in improving the gait pattern. So we always see the parietic side here, see what is happening to the parietic group of muscle, how they are contracting in the different phases of the gait. What are the background behind this use of functional electrical stimulation? It is proposed that patient stroke may have some unaffected pathways preserved, but these may not initially obvious. By using EMG biofeedback system, it may be possible for individual to learn how to use these preserved pathways. They may then be able to control muscular activity in order to recover motor function following stroke. That means those unused pathway still remain after GAIT pattern. They, by using this biofeedback system functional electrical stimulation, those reserved pathway are stimulated. They also helps in improvement of GAIT. So what the literature says about that, that this is this is study on electromyographic biofeedback therapy for improving limb function after stroke. This is a systematic review and meta-analysis. This result says that this 10 studies enrolling 303 participants, electromyographic biofeedback therapy can effectively improve limb function after stroke. However, there is a short-term improvement after EMG biofeedback therapy was supported, while evidence for long-term, that is more than or a months period, benefit is lacking. So here also there is a short-term benefit, but this is more useful for upper limb function rather than lower limb function. This is another Cochrane review database. They have studied EMG biofeedback for recovery of motor function after stroke. They have taken 13 trials involving 269 patients. All trials compared EMG biofeedback plus standard physiotherapy to standard physiotherapy alone. They compare and they conclude that despite evidence from small number of individual studies to suggest that EMG biofeedback plus standard physiotherapy produces improvement in motor power, functional recovery, and gait quality when compared with the standard physiotherapy alone. Combination of all identified studies did not find a treatment benefit. So overall, the results are limited because the trials are small, generally poor design studies. So this study says that the traditional method has a still has a role, but yes, when it is the EMG biofeedback is combined with the traditional method, that gives better result. So here they conclude that biofeedback constitutes strong level 1 evidence for positive benefit of GAIT, yes, in the early stages of stroke. But again, I would like to highlight here is that we should not forget the traditional methods of GAIT training. Whatever instrumental method we are using for GAIT improvement, but we should not forget the traditional method, whatever the evidence says about that. And this is the last method of improvement GAIT. This is used for other purpose also, like spinal cord injury most commonly used. This has started initially with the spinal cord injury GAIT improvement, but subsequently it is extended to stroke management also. Here the stimulations are mostly on the ankle dorsiflexors and over the peroneal nerve, and that also it stimulates the quadriceps to prevent knee buckling in the stance space. So basically, FES system is more, it was first developed for the spinal cord injury patients, but for stroke patient, it is mostly used for the ankle dorsiflexors to use for the dorsiflexion, so that the upper lengthening can be reduced and the limb can be, the circumference can be reduced. These electrodes can be implanted or can be surface mount. What are the therapeutic effect of functional electrical stimulation in case of stroke? They have a central effect, they have a peripheral effect. The central effect is by stimulating the afferent sensory system by FES triggered afferent feedback may facilitate the persistent brain plasticity, and when you stimulate the motor nerve, that also act in antidromic way for stimulating the sensory system. As far as the peripheral effect is concerned, it improves the muscle strength, flexibility, range of motion, and muscle spasticity of the paralyzed. As it is a direct muscle stimulation to the muscles, it also stimulates the muscles and increases muscle strength and flexibility. So it acts in both way. It acts by stimulating the sensory system, thereby stimulating the brain, increasing brain plasticity. Other way also improve the muscle performance by stimulating the muscle directly. So here also the 9 RCTs are taken. The common criteria are chronic stroke, able to walk with or without walking aids, no significant balance deficits are there as an inclusion criteria, and able to familiar with the APS system devices, and must have a good cognition. So these are the different studies. The latest one is 2016, where APS applied for 25 minutes, 15 days for 3 weeks with active cycling. They have found that there is improvement of cycling and walking ability post acute stroke period by using APS. And other studies also shows similar pattern. 2020 also another study shows that there is a greater improvement in static and dynamic balance abilities in the experimental group than in the control group. So some extent this shows a better improvement. You can say it is a passive method because we are stimulating the muscle and we are getting the action. Once the stimulation is stopped, the action may be limited, but the muscle strength, the muscle stretchability, the spasticity will be reduced as a peripheral action. So to conclude this regarding APS, there is a strong level of evidence that APS and in gait training results in improvement in hemiplegic gait. APS in improving physical performance, the muscle strength. It facilitates static and dynamic balance activities by strengthening weakened dorsiflexion in the swing phase and hip abduction in the stance phase to support weight bearing and upright posture. Now, what is the effect of orthosis in improving the gait pattern? If you look to the study presented in Prosthetic Orthotics International National, if you see that there is always debate what to give, whether to prescribe a articulated AFO or to prescribe a simple AFO, non-articulated AFO. That's always a debate. But as the study says that for use of orthosis, if you are using a non-articulated AFO, the gait improvement is better in the recovery phase. In the maintenance phase also supports that non-articulated AFO also improve the gait parameters. We see that gait improvement in the maintenance phase is using non-articulated AFO. In the recovery phase also, the non-articulated AFO also improves the gait parameters. So this study says that supports the use of non-articulated AFO. Whether to go for a barefoot or with a ankle foot orthosis, whether we'll allow the patient to walk without a orthosis AFO or will you advise AFO if at all, whether you are prescribing a non-articulate AFO or not. If you see that walking speed and cadence under barefoot and ankle foot condition, if you see that the ankle foot orthosis, there will be significant improvement in case of barefoot. Here the improvement is not significant. So this is all about evidence says that what type of methods you will follow for gait improvement in stroke, whether to use orthosis or not. If you are using orthosis, what type of orthosis? If orthosis is not available, so there is study which comparing without orthosis also what is happening to the gait. But all studies says that there is always when the orthosis is concerned, if is certainly improvement helps in ambulation as it maintains the dorsiflexion, it helps in ground clearance, it stretches the plantar flexors, so thereby improving the gait pattern in stroke. So this is I can understand this is exhaustive study. That's good for the students for appearing what is different methods of gait analysis, methods using for improvement of gait or treatment or management of gait in stroke patients. So, but please don't forget about the traditional method of treatment for stroke. So this is all about. Is there any question regarding stroke management? From our side, from our students? My purpose of presenting this presentation is that we should not forget about the traditional method of gait training, how you go for a simple missed task training, which component of the gait is missing, that component has to be trained and retrained by repetitive task training. Repetitive task training is always helpful for the upper limb function, but however it can be helpful for the lower limb also. As you said, see in this case, And if you look for other modalities of gait training, everywhere the same thing is that we are repeating a task, and repetition should be done by instrumental means to improve the improve the repetition of the same type. I mean, there should not be variation from first step to second step. So there's evenness. The equal parameters of the gate has to be maintained in each cycle of the gate. That's the help of a using the different types of instruments. However, this is not possible in case of traditional thing, because you never in the first first stride period, if the paratic limb is have a one step length, in second stride the step length will be different. So, but it should not be. For repetitive task training, both the stride length in the both the cycle of the gate should be similar. That is possible in case of instrumental gate training. That is possible, but that's by a machine, by equipment, so that maintain the symmetry of the gate. And we need a symmetry action for any sort of repetitive task training.
Sir, one question from chat box. Any
Yes.
related journals on PERFES?
Sorry.
Any related journals for FES?
I have supported these journals related to that. There are amples of journals in that. So I have given the reference for that. You can follow those things. Some of
Yes.
the journals are quite old, but current journals also coming. We can follow. So nowadays, referring journal is not a big thing. You have to find out something. So I have prepared this from the journals only. So you have to sit and find out the related journals to that. But again, the same thing that whatever systematic reviews we are following across the total presentation, all the outcomes are inconclusive. That some RCT says that yes, it is helping in improvement of gait. In other way, again, another systematic review is showing that it is result is inconclusive. But we must follow the principle that what is the abnormality, and how, from as a physiatrist point of view, how we can target those abnormalities.
Sir, one more question. After finding many deviations from normal gait pattern on gait analysis, which parameters to correct first by the traditional method? Symmetry, speed, or all together?
I think I have presented that one. Symmetry is that aesthetic has a limited role in functional achievement. Aesthetically, it looks better, but gate speed and distance cover is limited if you target only aesthetics. So this is again is a things that whether you focus on the aesthetic part or you focus the overall performance. If you look to the overall performance, then we have to compromise in the aesthetic part. I think on 10th or 11th slide was that only.
Sir, one more question. If we have to tell in exam about traditional method, how will we explain it? Sir?
Yes. So I have briefly also explained that you have to see the what is the type of gait. Mostly you will get a hyperextension gait, knee gait, or circumduction gait, or traditionally we call it is a gait in stroke. So, or hemiplegic gait. So in that situation, you have to look for which state. If it is a the flexor synergy has already appeared, what is the status of the upper limb synergy? What is the status of lower limb synergy? Very often when the patient start walking, they are always in the lower limb in extensor synergy. So you will find that there will be hyperextension of the knee, plantar flexion of the foot and ankle, and incomplete knee flexion. So these are the three observations you will get on observational gait analysis in case of hemiplegic gait. So for breaking that synergy to achieve more gait symmetry, we have to look for the knee flexion and ankle dorsiflexion. That is by doing repetitive task training and breaking the extensor synergy. Both can be achieved, as I said, if the patient is ambulatory with or without assistance, then you have to break the synergy by giving repeated flexion of the knee and dorsiflexion of the ankle. And the simplest way of achieving that is to ask the patient to get up from sitting position from chair, or half squat and straight forward, or step up and step down. All the time you are stretching the dorsiflex, plantar flexors, you are flexing the knee. So this repeated task will improve the gait pattern in traditional methods of gait training. And if the patient is non-ambulatory, ask the patient to lie down on the couch and hang the paretic side on the side of the couch, and ask the patient to elevate the limb up, and assist in knee flexion and ankle dorsiflexion. So this, by doing repetitive ankle dorsiflexion and knee flexion, elevating the limb over the couch. So by help of therapist, or you do it yourself, so this helps in improving the gait. This is how we'll answer, correcting the breaking the extensor synergy, improving the gait pattern by traditional method of gait training in stroke.
Sir, next question. Your experience with FES device and approximate cost of the device.
No, I'm sorry, we don't have I don't have personal experience APS for this. Regarding that, what is the effect, I have shown from the literature only. Personally, I don't have experience, but in our PT departments they are using. I personally, I don't have experience. But again, I would like to say it here that APS really started from the these spinal cord injury patients. But in those cases, we know that the recovery chances are poor, that improves gait by stimulate the muscle directly. But here in stroke, improvement chances are very high, and they in long run they improve the gait. The purpose of FES is to keep the muscles motor units intact, to relax the spasticity, to maintain the motor endpoints, and also to for a temporary period of muscle action, like for a dorsiflexion need to be stimulated, for dorsiflexion, and the hamstrings need to be stimulated, and the quadriceps need to be inhibited for late stance and early swing stage and mid swing stage. So this is the function of these things, and it has more role in spinal cord injury rather than this stroke patients.
So next question: if balance issue is there, can it be corrected by traditional training?
Balance issues by traditional training. Yes, the same therapeutic modalities as used for other balance methods. If the patient has ambulation but balance issue is there, he is ambulatory but balance issue is there, then you can use wobble board. You can use single leg standing with vision, with eye opening, without eye opening. This way, again in other advanced forms, I don't have knowledge on therapeutic part.
Sir, in non-articulated AFO, what's your opinion about solid ankle foot orthosis and PLS-AF, posterior left spine AF?
This PLS AFO is basically helps in this foot drop in swing phase. It has a limited role in stance phase. So if the patient is typically is having a spastic plantar flexion deformity in swing phase, the foot is going to foot drop. As toe dragging is there, then it is helpful. But if there is the plantar flexors are severe spastic, you need a solid AFO, non-altitude AFO, which helps maintain the stance phase. This lifting AFO has no role in stance phase. It has only role in swing phase.
Sir, next question: will mirror therapy helpful for lower extremity?
Yes, mirror therapy is a part. I have missed that part in this my presentation. Yes, mirror therapy is a part of this gait training part. Gait symmetry by repeated input to the patient himself, looking towards the parietic limb, how the parietic limb is moving. Yes, it has a role in gait symmetry.
Sir,
But it
how
has a least
aggressively?
role in gait speed, cadence. It has least role in that.
Sir, next question: how aggressively spasticity should be managed in post-stroke patient as it helps in standing and gait?
Now you have to select which group of muscles are affected. If it is a chronic stroke, it is a early stroke. In the post-stroke period, nothing to worry as traditional methods of spasticity management will follow. But if it is a chronic stroke, then probably we have to go for other modalities of spasticity management like Botox and others.
Sir, I think no more questions are there.
Maybe I'm not the appropriate person for presenting this presentation. So I tried my level best to give you evidence that how different modalities helps in improvement in the gait. Uh, hope you all have enjoyed the presentation and keep there are the references are there in the my presentation. You can go through these references. You can go through original papers in that. I will get more details from those papers. And we must have a basic knowledge on identifying the gait, what are the gait abnormalities in each stages of the gait, starting from what are the kinematic problems of the hip, knee, foot, and ankle. And each component can be addressed. Some part can be addressed by therapy. Some part can be addressed by other modalities like stretching, casting, splinting, buttocks. Those things can be managed. So certainly we have a great role. We cannot ever leave everything for the therapist. We have also role for improving gait in case of stroke. I hope the presentation will be helpful for you people. Thank you very much for joining the webinar. I must thank all the office bearers of IAPMR for providing the platform, Zoom platform from the IAPMR side for presenting this webinar every month. And hopefully we'll also continue webinar in coming months with good topics from good presentators. Thank you very much. Thank you.